Okay, we would like to welcome our next presenter, Dr. Andrea DeCensi from Galleria in Genova, Italy. And he will talk about the 10-year results of the phase 3 trial of low-dose tamoxifen in non-invasive breast cancer.
Thank you. Good morning, ladies and gentlemen. Thank you to the organizer for the opportunity to share our findings in this prestigious meeting. These are my disclosures. So TAM-01 is a phase 3 trial in women aged 75 or younger with high-risk lesions, including IDH, LCIS, or ER-positive or unknown DCIS, who were randomized to tamoxifen 5 milligram per day for 3 years, or baby TAM, or placebo, plus at least 7 years of follow-up. The primary endpoint was incidence of invasive breast cancer, or DCIS. We enrolled 500 participants from 14 centers in Italy. A visit and quality of life questionnaire were administered every 6 months for the first 3 years, and then an annual mammography and clinical visit was performed thereafter. The baseline characteristics of the subjects and the tumors were evenly balanced between the two arms. The mean age was 54. Roughly 40% were premenopausal. Mean BMI was 25. 20% had ADH, 10% had LCIS, and 70% had DCIS, 2/3 of whom were treated with the radiotherapy if they had high-risk characteristics such as young age, G3, or comedonecrosis. So 4 years ago at this meeting, we presented the 5 years data of baby TAM, which show a 52% significant reduction of recurrence and a 76% significant reduction of contralateral breast cancer. There was no difference in serious adverse events, nor was there a difference in patient-reported outcome, except for a less than an extra hot flash per day on baby TAM. Today, we will not present further follow-up data on PROS because we stopped, of course, to record these questionnaires after the 3-year intervention period. What happened after San Antonio 2018? ASCO and US Preventive Services Task Force guidelines included baby TAM for preventive therapy in high-risk lesions. NCCN recommends baby TAM after DCIS if patient is symptomatic or unwilling, unable to take the full dose. And perhaps more importantly, baby TAM has become the most popular treatment in high-risk lesions in several prominent US centers, with lower discontinuation rate versus 20 milligram tamoxifen or raloxifene or aromatase inhibitors. So today we are presenting the 10 years data. The main question was, is there a carryover effect with baby TAM as with 20 milligram per day for 5 years? So we perform an annual follow-up with mammography and clinical visit or telephone contact. The primary endpoint was invasive breast cancer or DCIS. We adjudicated 66 primary breast events, and the analysis is based on a median follow-up of 9.7 years. These are the main findings of our study. There is still a significant 42% reduction of the primary endpoint with baby TAM, which, as you can see, continues until up to 10 years or more with a nice carryover effect. Looking at subgroup analysis, there was a non-significant 32% reduction of ipsilateral breast events with baby TAM and a significant 64% reduction of contralateral breast cancer with baby TAM. There was no evidence of any significant interaction on subgroup analysis. The benefit seems to be evident across all subgroups, perhaps except current smokers, but taking into account that this moderate scale trial was not powered to detect interactions. Interestingly enough, there was a significant reduction in postmenopausal women, in obese women, which is interesting, in women undergoing mastectomy, and in the DCIS cohort. In the DCIS cohort, there was a remarkable 50% reduction of recurrence with baby TAM for 3 years, which to us provides a new standard of care in this cohort. So the tumor characteristics of the 66 events were not different between baby TAM and placebo. The majority of recurrences were invasive, ipsilateral, and T1 stage. There was no evidence of any difference in the molecular phenotype between the two arms, nor was there a difference in Ki-67. Our 10 years data confirm the safety of this approach. We didn't see an excess of endometrial cancer. There was one case of stage 1. We predicted 5 using the NSABP1 data with 20 milligram, and we saw no difference in deep vein thrombosis or pulmonary emboli, predicting 3.5 with a full dose. There was no difference in other primary tumors, nor was there on coronary heart disease and bone fracture and other serious adverse events. Interestingly, cataract and endometrial polyps, which are two non-serious but frequent adverse events with the full dose, were not significantly increased with baby TAM. Death from breast cancer was shown in 3 cases, 0.6% with no difference between the two arms, nor was there a difference on the overall death rate. What are the limitations of this study? As I mentioned, limited power for interaction and subgroup analysis. The lack of a vis-a-vis comparison with 20 milligram day. However, a non-inferiority trial would be poorly accepted in high-risk lesions due to the toxicity of the 20 milligram dose. Finally, the lack of the 5 milligram tablet on the market is a limitation with this drug with 0 commercial interest. But 10 milligram on alternate days is a reasonable choice due to its long half-life. What are the clinical and research implications of baby TAM? Certainly, the reduction of breast cancer in high-risk lesion with the new potential standard of care in DCIS. We think that the effect on contralateral breast cancer reopens the door for prevention in high-risk unaffected women. Baby TAM can provide an option to treatment cessation in intolerant to 20 milligram women in the adjuvant setting. The unmasking effect of baby TAM, which may lead to a reduction of interval cancers in premenopausal women with dense breast, as already pioneered by the Swedish group in Stockholm, and potentially a risk reduction in young women after chest irradiation, as shown in a phase 2 study with surrogate biomarker in this country, and possibly an interesting trial, a risk reduction in moderate penetrance genes such as PALB2, CHEK2, or ATM. In conclusion, baby TAM, 5 milligram per day for 3 years, lower recurrence from non-invasive breast cancer after 10 years with a carryover effect and without adverse event excess. There was a benefit across all subgroups, though with limited power. The low risk of death, 0.6% at 10 years, strengthens treatment de-escalation in DCIS. And TAM is one more example of a missed optimal dose for a targeted agent, as recently denounced by the FDA, and as we have seen in this conference for many drugs. Finally, I want to thank the contribution of participants and their families. The study was supported by my hospital, the Ministry of Health, and 2 charities. We thank our sponsor for the academic no-profit trial aimed to attain a safe, equitable, and affordable medicine with a treatment which costs $2 to $3 per month. The comparison with the modern treatments is merciless and embarrassing. And finally, my pledge to the young investigator. Please do not miss the unique beauty of academic clinical research, despite the threats by a devastating bureaucracy. Our scientific agenda cannot be only dictated by Big Pharma. Thank you for your attention.
So there are a couple online questions. One is from Doug Yee. Do you have any data on bone density in the postmenopausal group, recognizing that fracture rates were not statistically different, but numerically higher in the baby TAM group?
No, we didn't measure bone density in our study, so I just can rely on the data on other biomarker studies that we have performed in the past where there was no evidence of any detrimental effect on bone density.
Very good. And in person, I believe we have a question at microphone 2.
Yes, Steve Nayrod. A very good talk, Andrea. Yeah, I only have one question. How do we get the women to take it?
Can you speak aloud?
Yeah, sorry. The question I have is, not facetiously, how do you think we should go about getting the women to take the drug?
So I think in this country, at least, the drug has become very popular. The problem is in Europe, but Nemo is prophet at home. But for instance, in my country, our regulatory agency thinks that I should perform a non-inferiority trial with 20 milligram, which I don't think is very clinically meaningful.
And at microphone 3.
Mitch Nowsett, London. Andrea, that's lovely stuff. I concur with what you were saying about this being the wrong dose, if you like. 5 milligram is better than 20. But you've done biomarker analyses which suggest you can go lower still. Do you think you've got the right dose now?
Well, the Swedish group has shown that 2.5 milligram has the same effect than 5 in lowering mammographic density in premenopausal women. We had shown in our pre-surgical trial on Ki-67 that 1 milligram per day was non-inferior to 20 milligram dose as well. So, yeah, we didn't have the courage to go so much down, but I think it remains an open, which is the minimal effective dose of tamoxifen is still a question to be addressed.
And one more at microphone 4, please.
Thank you, Marie Wood from University of Colorado. Andrea, beautiful study, and I share your enthusiasm for using this in the US, and it is very well taken up. But I'd like to see if you can comment on what you think is your optimal design for the next step in a study.
So, thank you for your question. We have done a baby exemestane trial with the NCI support. It is a biomarker trial, so it's under review. But I think that the next step to me is a vis-a-vis comparison of baby TAM versus baby X in high-risk postmenopausal women.
Thank you.
Thank you.
Thank you.